Welcome to your online lecture for upper extremity injury evaluation. This will serve as a brief review of the orthopedic examination process. If we're really honest with each other, you guys have been living this for the last semester. So I imagine that this review will be short and brief, and I will go through slides quickly, but these slides will also be in the module. Again, this is just a review, so there shouldn't be any new information added to this, but I always would like to start our orthopedic eval classes with a very basic foundation to make sure that we're all on the same page. So here we go. When we're thinking about the examination process, we have to be thinking about what it is as a whole. To me, when I think about the examination process, it's you being a detective, right? And trying to connect all of the findings of your assessment or evaluative process, right? And that's going to kind of have you take a look at dysfunctional anatomy, maybe even physiology, depending on the pathology, and or aberrant movements or disruptions in joint biomechanics, right? And you're going to take all of your findings in your HIPS assessment, kind of bring them together to come to one conclusion or one diagnosis, right? And so when we think about the examination process as a whole, it's very holistic, right? It's going to involve objective assessment. It's going to involve historical assessment. And it's also going to hopefully involve, I'll make the argument that it should involve subjective assessment or patient-rated outcome measures over time. The overall ultimate goal of the examination process, however, is really written down here. It's really the process of differential diagnosis, is the process of ruling out certain specific conditions to be left with a condition or two that we really truly know that it is, right? And that'd be the process of ruling in the pathology. When we think about history, though, I kind of want to talk about two different medical models, because there certainly are the way that healthcare practitioners are trained will depend on the medical model in which they live. So the first type of physical examination or assessment technique that most healthcare practitioners use is what we call the traditional medical model. And that's going to include those that are trained to be a physician assistant, a nurse practitioner, and obviously a medical doctor, right? They live in what we call is the traditional model of physical examination or patient assessment. And that is going to include some key areas that cross over into the orthopedic examination model of assessment, which is where most athletic trainers, maybe even physical therapists, occupational therapists might live. So in that medical model, like the orthopedic model, it includes inspection and palpation. So we're looking, we're observing, and we're touching the patient. I think that's where we have a lot of the overlap. But then we certainly can see that in the medical model, they're going to spend a lot more time in the auscultation and percussion components in a patient evaluation. And by auscultation, I mean heart, lungs, right, and abdominal listening. And then on the percussion side, we're referring to something that maybe we have an internal organ injury, and we're trying to determine whether or not they're bleeding internally. We'll do tapping to produce different sounds to tell us whether or not there's more compromise to that abdominal cavity. So we can already see there's vast differences, right? They have maybe a broader training array. And then we move down to the orthopedic examination model, which involves the HIPS model, right? We've lived through that in lower extremity. We understand that we have to take a thorough history, which involves not only past medical history, but also current medical history, that we should always start our inspection or our observation as soon as that patient walks into the clinical setting. That palpation is a key foundational component to determining where we actually see dysfunctional anatomy or aberrant biomechanical movement patterns, right? And then last but not least, we utilize an array of special tests to help us either rule in or rule out the pathology. And so there are definitely differences between the two medical models, but on the next slide that I'm going to show you, you'll see that there's overlap between the two as well. Now, there are two terms that are often thrown out, which do absolutely mean different things. And oftentimes in the field of athletic training, we oftentimes get told that we can't diagnose a pathology. But I'm going to ask this question to you. Which of these do you think we do? And then I'll kind of give you the answer once I'm done with that. The word diagnosis comes from the Greek root word, which means to discern, right? And if we take it at face value for what it is, it's to determine the cause or nature of a pathological condition, or to name the actual disease or injury in our case. So do we diagnose? We absolutely diagnose. It's the reason that we do or go through a systematic patient evaluation. It's to name the disease, right? To identify the pathological condition. We're going to use our clinical special test to do that. On the opposite end of that is assessment. And I like to think of assessment as the overarching theme of patient evaluation. It's what we do. So we're using a broad array of techniques, whether that's history questions, special tests, palpation, inspection, right? We're using a broad array of techniques to collect information about the patient's condition, right? Which will help us ultimately do what, you guys? It'll help us come up with the final answer, which is going to be the diagnosis. So to me, assessment and patient diagnosis are linked, right? The process of assessment is what allows us to diagnose the patient's pathology. So as athletic trainers, as healthcare practitioners, we certainly do both. The process of patient evaluation or patient assessment really leads us to the end goal, which is the patient diagnosis. So I mentioned on the previous slide that I would bring the two models together to say that they're really linked, even though there are aspects of the model that maybe we don't use very often. I hope that by the time you leave our MSAT program that you will be equipped to auscultate and the cardiac region, or that you will be equipped to auscultate the abdominal region, right, and listen for bowel sounds, just as much as I hope that by the time you leave us, if we have an acute pathology in the abdominal region where you suspect internal bleeding, that you'd be able to percuss and know the different sounds, right? But certainly our focus as an orthopedic driven program is to make sure you are really good at the HIPS component, the orthopedic model of assessment. That isn't to say that some of you will not go into orthopedics or sports medicine, and that some of you might actually have aspirations of being a PA or an NP, and maybe even a physician. And so we hope that we combine the two. And what we really do is prepare you to transition to practice and to work with interdisciplinary professionals through the process of differential diagnosis, right? This process of really, truly kind of weeding out all of the pathologies and kind of being left with one or two pathologies that you believe that it is. So we're in differential diagnosis, and I think I have hammered this more than enough in the previous semester, but another spin on differential diagnosis is this concept of it being this systematic method of diagnosis that really determines which of a variety of conditions are present or aren't present. And we typically do this through the process of elimination or the process of ruling out a pathology. And in the upper extremity, one such way to look at this is to think of it this way, that there are multiple conditions in each joint that will present with similar symptoms, right? That's across the body. So the question becomes, how do we determine which condition we actually have sitting in front of us? And one condition in the upper extremity that's very common and causes a lot of problems in differential diagnosis is sciatica, right? So some type of neuropathy or radiculopathy emanating from the lumbar spine that's causing some type of issues distally, right? So here's differential diagnosis at its best. A patient presents to us with sciatica. The first history question that we're going to ask is, where does the radiculopathy or pain go? Does it go below your knee? It's usually typically the first question. The answer is no, then we know that that's localized to the lumbar spine, particularly to the sacroiliac joint. And so our assessment is going to move towards more SI joint special testing, right? If the answer is yes, then we have to ask a follow-up question to that, which would be, do you have tenderness palpation in the gluteal region? Are you weak with abduction? Do you have pain with adduction, active contraction, passive stretch? If the answer is yes, then we're thinking more muscular piriformis syndrome, thick piriformis, maybe compressing on the sciatic nerve as it crosses into the gluteal region, right? If the answer is then no, then we're thinking maybe it's a lumbar disc pathology. So we can see there this process of differential diagnosis where we start with really three kind of pathologies in our mind through the process of history questions, right? We're able to ascertain whether or not a patient has a specific type of pathology. And then as we move from that bolded region, we can see that then we go into our clinical special test, which then will allow us to kind of come up with a diagnosis, right? And so it's this part right here that I consider to be the assessment part. And then it's this part down here where I would consider that to help us with our actual clinical diagnosis, what the actual pathology is. So when we think about differential diagnosis, I really want us to start thinking about differential diagnosis as this process of diagnosing by exclusion, right? This concept of us really ruling out all pathologies it couldn't be so that we can get to the pathology that it should be. And so we rule out, we exclude all pathologies, and we're left with that one. And this is where we'll start talking about sensitivity and specificity in a little while, where we would use highly sensitive tests to help us rule out the condition, the diseases along the way. So you'll remember in my, I think my differential diagnosis slide where I kind of had that, when you hear hoofbeats, look for horses and not zebras. Essentially what we want to do is make this process simple. Let's not dream up pathologies that don't exist. Let's look for the simplest, most common pathology first, and hopefully that's kind of what it is. But we also know that differential diagnosis is ongoing, right? So if our patient isn't getting better after our diagnosis, then after a few weeks with therapy and or rehab, then we go back and we reassess and we figure out, okay, what did we miss in this process? So it's ongoing. It's continuous is what I want to say. What are the goals of differential diagnosis? If you're a healthcare practitioner, why do we keep saying this across each class, at least evaluation class? The ultimate goal is for us to get to clinical diagnosis, to name the actual pathology. That's the process of ruling in. The other is to eliminate any life-threatening conditions. That's the process of ruling out, right? And then ultimately, when we're able to rule out pathologies and come to one conclusion or diagnosis, then we're able to treat that patient better because we're able to create a plan of care, create patient goals, create rehab protocols if we need to do that, right? And we're able to improve the patient's quality of life, which to me is probably more important than any of the other things listed there. So when we do these injury assessment outlines, the ones we've done in lower extremity and the ones that we'll do in upper extremity, the ultimate goal is to get you guys better at differentially diagnosing, right? Like hopefully you can see kind of the light at the end of the tunnel. They aren't just in the class just because the goal is really to help you guys start differentiating between pathologies that might actually look very similar in your patient assessment. So a word about models of examination. We talked about the orthopedic model, and we talked about the medical model, and the ways that they differ and the ways that they cross, or the ways in which they are alike, with the ultimate goal being differential diagnosis. And I think there's one area that they lack. All of the items included in each of those medical models were very objective clinician-based measures. And if we look at the new models and if we look at the evidence, right, we ended evidence-based practice class with patient-rated outcome measures. Because if we look at evidence-based practice, one of the things that we have to consider are the patient values, right? Does the patient perceive they're getting better with this plan of care, with this treatment, with this rehab? And that's a piece that's missing in those medical models. Like if we go back to the medical model and we look at this, we don't see in any of these models that patient perception, patient values are included. And that's really important in the process of becoming an evidence-based practitioner, that we're actually considering the patient's quality of life and the patient's perceived quality of life, not just based on objective goals, but based on what our patients are actually telling us. So that segues us into evidence-based practice, right, you guys? When we think about evidence-based practice, I really love this image here because it is a combination of three different things, the three different constructs that intersect. And the first one is, to me, that's most important, our patient values and how our patients perceive their injury or disease is progressing. It's clinical expertise. We wouldn't be where we are. You won't be where you are when you leave us if you didn't have clinical expertise. And what do I mean by that? You'll have done rehab on 50 ACL, so you'll have some clinical expertise on what works, what doesn't work with ACL patients, etc. And then last but definitely not least, and probably most challenging in the field of athletic training, is the best research evidence. In other words, creating or training up clinicians who not only rely on patient outcome measures, not only rely on clinical expertise, but really truly use the best evidence or search the literature to help drive clinical decision making. So in summary, for the Board of Certification examination, when we're defining that, it involves the efficient use of the best available evidence, right, to drive care to your patients in hopes that we're improving patient outcomes. And it also encompasses your clinical expertise. So if we're thinking about evidence-based practice, the reason that it's so challenging, besides being time consuming in the clinical setting, is that it requires you to critically think. It requires you to ask specific clinical questions. It requires you to be challenged, right? That you have this patient who isn't getting better with the rehab that you're doing. It requires you to challenge yourself as a clinician. And that's one of the reasons that we have a lot of pushback as it relates to integrating evidence-based practice into the field of athletic training, besides the timing component of that. But essentially what we want to do with evidence-based practice is really be purposeful in our thinking with individuals, both systematically in what we do, and habitually we want to impose these criterias and these intellectual standards upon our patients. So what does it look like to impose those intellectual standards, right? You're asking these questions. I just said that, right? You're asking these clinical questions. You're challenging yourself. You're wanting to make yourself better. You're wanting to search the research and the literature to find out what's new. What things aren't I using, right? What things aren't in my clinical expertise that might actually drive patient outcomes and make them better. And I think that's really one of the things that sets this MSAT apart from a lot of other programs is we want you to be good clinicians, but we want you to be able to also be good clinicians who have great patient outcomes, right? And so the only way to do that is always to be an evidence-based practitioner, to always be searching that research literature, right? And so if you ask me why evidence-based practice, if you ask the literature why evidence-based practice and why there's been this major push in the field of athletic training, really in the field of healthcare, is because insurance companies are no longer wanting to just reimburse for a treatment protocol or a rehab protocol or a diagnostic tool that isn't making the patient better. In other words, they want you to provide evidence of the efficacy and the effectiveness of your treatment. So why not use the research literature to drive your treatment protocol? Why not use the latest evidence to help drive patient outcomes? I know in the state of California, it's more difficult, right? Because most often ATs aren't reimbursed for their treatment. But if you move outside of the state of California, where athletic trainers can be reimbursed, then you'll see that this process of evidence-based practice in medicine is extremely important to patient reimbursement, right? Your insurance companies want to know that what you're doing is supported in the research literature. So one of the things that I want to focus in on this slide is right here, this old clinical adage. A lot of times in older days, we would just refer patients out for everything, to get an x-ray, to make sure that this pathology wasn't there. And so there's this old clinical adage of don't order a test unless it will alter the way that you manage your treatment. An example would be, an ankle sprain. If you're going to ice it, you're going to massage it, you're going to rehab it. And if audible rules are negative, there's no need to get an x-ray just to make sure you feel like you want to be right in your diagnosis, right? That would be a misuse of the medical system. And so that's one of the rules of evidence-based practice, is to prevent clinicians from just referring patients out all the time. Better yet, using the evidence to help drive and keep our patients in the clinical setting where we want to be with them, right, you guys? So we should know this level of research hierarchy by now, but when we are using research to drive our clinical decisions, we really want to be living in this arena, right? Anything below the lilac or purple, and that would be more subjective and shouldn't be used to drive our clinical decisions. But the cohort studies and randomized control trials, obviously systematic reviews are the gold standard of gold standards, but the reality is we don't have a systematic review for every single pathology that exists. So using any research in this area to drive your clinical treatment of a patient, it provides, makes you an even better evidence-based practitioner. So when we incorporate evidence-based practice into clinical diagnosis, I think this is where evidence-based practice has been really great for athletic training. It has reduced the number of special tests that we need to use in a patient evaluation. It's useful, absolutely, and we're going to talk about sensitivity and specificity in just a while. Just those two evidence-based practice statistics has really changed the way that most of us actually do or perform patient evaluations. It used to be that we would always just do every single ACL test and every single meniscal test. But now we live in a world where sensitivity and specificity for those tests are reported. So now we know which of those tests would be the best test to use to really rule in or rule out that pathology, right? So that's just food for thought there. So we're moving into diagnostic accuracy of special tests, and we're really going to spend most of the time talking about sensitivity and specificity, but it's important to understand what accuracy is, right? So accuracy can either be how often a test is actually correctly diagnosing or identifying that a disease or an injury is present, or how it can be how often a test tells us that the patient doesn't have the pathology. So it either tells us 100% of the time that they do or 100% of the time that they don't. In other words, it's always going to tell us the true positives, right? Or the true negatives, right? So a highly accurate test will have a high number of true positives or a high number of true negatives. And where we get really concerned is if there's false negatives and or false positives, right? We have a patient walking around who thinks they have a pathology and they don't. Or if we're thinking about cancer, we have a patient who thinks they don't have cancer, the cancer progresses, we catch it later on because the symptoms change. So we have a patient with cancer walking around who thinks that they don't have cancer. So we can see how things falling into each of these categories can be deleterious for patients in the athletic training setting. The hard part with diagnostic accuracy, right, if we're keeping it real, is this concept that we have to compare our clinical test to a gold standard. Most often that gold standard is going to be a surgical technique, right? The reality is surgery is so expensive and invasive and time intensive to recover. So we need really good clinical tests. And that's where our sensitivity and specificity are going to come in, because our sensitivity and our specificity are like cornerstones for how we decide which tests we're going to use first in a patient assessment and which tests we're going to use last in a patient assessment. And this is important. Sensitivity and specificity are always challenging for athletic training students to understand. So I'm going to start with the basic definitions, and then I'm going to help us understand how this clinically applies to us in athletic training. When we think about sensitivity over here, we're thinking it's the probability of a positive result in someone with the pathology, right? So that would represent the true positive rate. How well does a test positively assess a patient who has a pathology? It's the true positive rate. That makes sense to me. The other way to think about that is how accurately does the test detect those patients who actually have the disorder. So if a patient has an ACL rupture and we do a Lockman's, how often does the Lockman's actually detect that a patient actually has an ACL tear, right? Now that's typically going to be relative to the gold standard, which would be usually an MR, right, or orthoscopic surgery. So it's the true positive rate. But one of the things that we have to do is we have to think counterintuitively, right? Which is really hard to do because sensitivity is the true positive rate. How often a test detects a patient who actually has the disorder. But let's flip that test. Let's flip that definition on its head and let's say it this way, that a highly sensitive test is always going to catch most cases of the pathology. So we have to think counterintuitively in this way, that if the test is negative and it's highly sensitive, then we know that the patient doesn't have it because a highly sensitive test is always so good at detecting those that have it. So we have to use this now acronym, and we have to say a highly sensitive test, when it is negative, that it's going to rule out the pathology. And so these highly sensitive tests are used early on in the assessment process to rule out, right, in that differential diagnosis. On the opposite end of that, we have specificity. So that's going to be the true negative rate, or the likelihood that the test, that a negative result, that the probability of a negative result in someone without the pathology. Or another way to say that, how accurately does the test detect patients who do not have the disorder relative to the gold standard? So that's going to be our true negative rate, right? We know that a highly specific test will tell us will be negative if the patient doesn't have the condition. So we have to flip that on its head as well, because it's good at detecting those who do not have the condition. A highly positive test, a highly specific positive test, will rule in the pathology. So we have to think about those in negative terms. So how does this apply to us? How do we look at sensitivity and specificity, and why do we use these in our clinical practice? You guys, this is one of the best parts of becoming an evidence-based practitioner, because in lower extremity, you saw we had like 30 ACL tests. Maybe that's an exaggeration. When we get to the shoulder joint, you'll see there are an array of special tests. But what we can say about this is that some of those tests that we're learning don't have high sensitivity and or high specificity. So those aren't tests that we want to use. What we want to do is really use those highly sensitive tests very early on, and then those and rule out anything. And then we want to use those highly specific tests later in the exam to help us come to our diagnosis, right? And that is extremely important when we're thinking about differential diagnosis and the process of differential diagnosis. These two key evidence-based statistics really help drive our clinical decision making. The next evidence-based practice statistic that we really should talk about is the likelihood ratios. And you guys did a homework assignment with likelihood ratios and evidence-based practice. And so if we do a quick summary of this, when we think about likelihood ratios, it's a quick summary of how positive and negative findings determine a test's diagnostic usefulness. So with sensitivity specificity, we're saying, okay, the patient either has it or they don't, and then the likelihood of that patient actually having it is what the likelihood ratio tells us. So sensitivity just says if the test is negative, then we're certain they have it, but we don't know how certain we are, right? That's where the likelihood ratio comes in. Specificity, if the test is positive, we know that the patient probably has it, but this helps us determine the likelihood of the patient actually having the pathology. So the two, sensitivity, specificity, and likelihood ratios combined really strengthen our clinical assessment, right? And so I want to look at it from this perspective here. A positive likelihood ratio expresses the change in our confidence that a condition is present when the test is positive. So when we think about positive likelihood ratios, they are going to be linked to specific or specificity test. So a highly specific test is always linked to a positive likelihood ratio. So hopefully you got that, right? So a highly specific test, when positive, will rule in the condition, and then we look at the positive likelihood ratio to tell us how likely it is that that patient actually has that pathology. So positive likelihood ratios are usually linked with specificity test. Then we have the negative likelihood ratio, which expresses the probability that the patient that the pathology is still present even when the test is negative. So a negative likelihood ratio is most often associated with a sensitivity value. And so why do we want this? This is more counterintuitive. What we're saying is it expresses the probability that the pathology is still present even though the test is negative. So we want that negative likelihood ratio to be relatively low, right, if we have a highly sensitive test. Now, I'm going to look here, and so what we would say is, remember I said we want that likelihood ratio to be that negative likelihood ratio to be relatively low when we have a highly sensitive test, because when it's lower, then we know that if the highly sensitive test was negative, and then we have this low negative likelihood ratio, then we know that more than likely that patient does not have that pathology. And so we can move down this chart to kind of help us determine the conclusivity of the test. On the opposite end of that, the positive likelihood, if we have a highly specific test that is positive, we want that likelihood ratio to be larger than 10, and if that positive likelihood ratio is larger than 10, then we're really certain that the patient has the pathology. So I hope that made sense. But if not, this is my cheat sheet for most evidence-based practice stats, right? So the sensitivity, or the SNOUT, is going to represent the true positive rate. It's the proportion of patients who have a pathology that the tests identify as positive, and so it's going to be snouted out. A highly sensitive test with a negative result rules out the diagnosis. And that highly sensitive test is always most often going to be linked to a very low negative likelihood ratio, because remember, as we said, the negative likelihood ratio is like the likelihood that the patient doesn't have the pathology. So the lower that negative likelihood ratio is coupled with a highly sensitive test, then we know that patient, it's really likely that the patient does not have the pathology. The opposite of that with a highly specific test, it is a true negative rate, or it represents the patients who do not have the pathology when compared to the gold standard. So a highly specific test, when positive, will rule in the pathology, and that's most often coupled with a relatively high and positive likelihood ratio, typically over 10, and we are certain that the patient has it if the test is positive when we do it. One of the cool things that we're living in right now is a world of COVID-19 testing explained, right? And a lot of what we've seen in the earlier phases of COVID-19 were the sensitivity and specificity and the likelihood ratios of the different types of tests that we use. So if you're interested in diving deeper and applying evidence-based stats to the different types, rapid antigen tests, for example, PCR testing, for example, and looking at sensitivity and specificity and negative and positive likelihood ratios, and that's there for you to take a look at. But what I wanted to really finish with is this concept of the clinical usefulness of tools, of tests that we're going to learn in this class. And really, I want to make the argument for the special tests that we have really truly learned in lower extremity. All of these tests that we're learning over this year really are built to create a clinical toolbox for you to use in the process of differential diagnosis. Some of those tests are going to be highly sensitive, some of them are going to be highly specific, and some of them are not going to be anywhere near useful. You're still going to learn them, and some of you are still going to see them being practiced, right? So what I would love for us to do is move away from a model where we are just performing every single special test for that particular joint, versus really truly using the evidence to drive which special test that we're actually using. The reality is some of our clinical special tests don't have sensitivity and specificity values. And so then we just have to rely on what? Our clinical expertise. Has this special test been a good special test to rule in and rule out specific pathologies? That's really kind of all that I have for you in this particular online lecture. The last thing I'll leave you with are these things called clinical decision rules, which are different and distinct from evidence-based practice, but still use evidence to drive decision making. The clinical prediction rules, there are a few sets of those, one of those being the Ottawa ankle rules, the Ottawa knee rules, and we'll learn about the clinical decision rules for low back pain and treating low back pain patients when we get to that segment in this class. But what we know about clinical decision rules is they are a group of findings that when they come together, improve clinical decision making, decrease costs. For example, with Ottawa ankle rules, it reduces the number of patients who are coming into the ER for x-rays, and it improves patient outcomes because those patients are getting treated quicker and faster in the healthcare setting. And so I said the Ottawa ankle rules is an example of the clinical prediction rules. Like, we can predict whether or not the patient actually has a fracture based on 4 palpation sites and their ability or inability to walk, right? And so this is an example of a way that we reduce costs, because we're no longer sending the patient into the ER. So we're reducing the cost from the insurance side, but then also from the patient side for that particular patient visit. And we improve outcomes because we're able to treat that patient differently, right? Less conservatively than if they had a fracture. So if you want to consult and look at higher level evidence research articles, so, meta-analyses, systematic reviews, then Cochrane's going to be best for that. But you already know you have EBSCO hosts, which is free of charge for you as students. And so I encourage you to use those to drive clinical decision making, even as a student, but certainly when you transition to practice. So what we're going to do eventually when we get into the classroom setting is work through different examples in the current literature. Really thank you for listening to this. I know it's a review and I probably went through it fast, but this should be relatively review information for you all. See you in class.